Hello, my name is Kim Durand. I'm a student at Western Governors University, and today I'll be discussing depression in the elderly. According to the CDC data of 2015, 80% of the elders 65 years of age and older have at least one chronic disease. 50% have two or more. Add in depression and the risks and complications increase. Research suggests that depression is commonly undiagnosed in the elderly, leading to complications with exacerbations in their other chronic disease processes and functional decline with increased frequencies of falls and injuries. This presentation will address three main points about depression and its effect on the elderly population. First, how nurses can identify depression in the elderly. Next, how depression affects elders with coexisting chronic diseases. And finally, how depression is related to increased incidences of falls and injuries in the elderly. Why is depression not identified? Many nurses are not familiar with assessing for this disorder. And according to Mock in 2009, many clinicians see depression as a normal part of the aging process. Common signs and symptoms of depression are sadness, lack of enjoyment in previously enjoyable activities, significant weight change, sleep disturbances, restlessness, fatigue, feelings of worthlessness, impaired ability to think clearly and to concentrate, and suicidal ideation and attempts. Elders will generally not report depression as depression. In fact, they will probably report an increase in somatic complaints. Some examples are sleep disturbances, pain, and loss of appetite. Use of validated tools to screen for depression are important in the identification process. Phelan in 2010 conducted a study looking at the validity of the two most commonly used tools, the Patient Health Questionnaire, or PHQ-9, and the 15-item Geriatric Depression Scale. Both of these tools are a series of questions. The person answers these questions and provides a self-report of symptoms. The scores are tallied, and a final risk score is achieved. The PHQ-9 score range from a minimal depression through severe depression. The Geriatric Depression Scale looks at a score of 5 or greater as suggestive of depression, and 10 or greater indicative of depression. These tools are available online with the instructions for use, the Patient Health Questionnaire, PHQ-9, 2015, and Greenberg, 2012. The full references are attached at the end of this presentation. According to Sackham and Roos, 2004, depression itself is a predetermined risk factor for other illnesses such as heart disease. Evidence shows that elders are unable to engage in self-management activities when they have depression. This leads to disease exacerbation and hospitalizations. The ability to self-manage your disease can lead to adherence, which can slow the process of chronic illness. Physiological and hormonal effects of depression also impact all organ systems. Imbalances can lead to cardiac arrhythmias, hyperglycemia, cerebrovascular issues, and high blood pressure. Depression can also affect how the brain works. Overall cognitive decline is seen in elders with depression, and depression is frequently associated with dementias. Why does depression predispose elders to falls? The Department of Gerontology at the University of Massachusetts in Boston completed a study led by Koch in 2013. It identified elders with depression as having an increased rate of falls at 62% for indoor falls and 60% for outdoor falls. The research determined the reasons for falls are multifactorial. Koch's study, however, did find factors that stood out. The psychological reasons such as decreased concentration and non-adherence to therapy. Certainly the biological reasons and the close correlation of depression to other chronic illnesses. The medications used to treat depression, usually antidepressants, cause changes in fluctuations in blood pressures, gait and balance disturbances, and sensory changes. Finally, functional decline is present in elders with depression, and depression exacerbates functional decline. It was seen that elders have fears of falling, they're socially and functionally isolated, and due to these issues, elders stop doing activities that previously helped them keep mobile. Increased falls also increase risks of injury. Behind me, you'll see some data from Koch's study looking at the rate of falls per 100 persons related to clinically significant depressive symptoms and use of antidepressants. The last two columns are patients who had increased clinical signs of depression, one without antidepressant use, one with antidepressant use. Both exhibit increased falls. Research suggests that depression is commonly undiagnosed in the elderly, leading to complications with exacerbations in other chronic disease processes and functional decline with increased frequencies of falls. Depression in the elderly can go undetected if nurses are not aware of what they're looking for. And according to Mock in 2009, it is important to understand that depression is not a normal part of aging, and intervention should be applied to decrease the risk for these individuals. Elders with depression are predisposed to chronic illness, and chronic illness is exacerbated by depression. And finally, depression in the elderly population increases the risk of falls and injuries. The identification of depression in the elderly is an important issue. Proper identification will assist in decreasing the risks and complications associated with this devastating illness. I urge all nurses to keep the signs of depression at the forefront when assessing and interacting with elders. I want to leave you with one final statistic. According to Mock in 2009, 63 to 90% of elderly individuals with depression go untreated. Thank you.